and thanks for the invitation to talk in this conference. I'm Nicolas Martinez, a consultant hematologist and CLL lead in Nottingham. I'm going to talk to you today about the UnCoVer Plus, which is probably one of the largest sort of dataset projects that has been undertaken in the UK for cancer data. And what pertains to us today is what does it have about CLL. So the UnCoVer, a brief overview of it, is a project that has been hosted by the University of Liverpool and the Clatterbridge Cancer Centre under the leadership of Dr. Pettit, and is basically originally designed to investigate the outcomes of COVID in CLL and all the cancers. But then it has expanded to be included as a project looking at other malignancies and sort of real world outcomes of these malignancies. So perhaps this shows with a bit of a greater detail what does it entail. As you can see, the part one on the top is the original part of the UnCoVer project, and the part two, which is on the right hand side, is kind of what we call the UnCoVer Plus, and you can see actually the plus is probably allegedly quite bigger than the part one, and it includes several work packages, as we've called them, that are focusing on each one of the sort of relevant, we thought, hematological conditions, but not only sort of specifically related to this or sort of circumscribed to these. There's the option to expand that to potentially other rare conditions as we go along. So what we want to interrogate of this data set in the part two, as you can see in the bottom part of this slide, is what are the changes in cancer pathways, diagnosis and treatment, the disparities, what are the effects of the novel treatments, and there's a fourth item there, kind of not very explicit, just answer any questions that we can think are relevant from these data sets that would be helpful for each of the specific communities. So we have constituted these work packages, which are essentially working groups that include clinicians, statisticians, and patients as well, trying to sort of identify research questions that could be answered with this data set and that are relevant. So there are a number of existing population data sets. As you can see here, the three really good examples of that. The top left is the one from the Netherlands, the Dutch Cancer Registry, which has given significant and very relevant data to the CLL community. The one on the bottom left is the Danish Cancer Registry, which has also given quite a significant information. And the right-hand side one is the British Columbia in Canada, which is also done significant advancements. So these three are sort of population-based registries on sort of very circumscribed populations, as the Dutch, the Danish, and the Canadians in British Columbia. And they just record all the data for all their patients that are being treated, nearly for all the hematological malignancies, and they have excellent data, not only for CLL, but also for others' data. And we've always been very envious of these groups and sort of the wealth of information they always have. They produce these publications that are just really important, to be fair, and give us good information. So we said, what can we do? Can we really do this with the UnCoVer Plus? Can we emulate this and do sort of a strong UK data set for the benefit of the international community, but also for our own, because the data we've got for CLL is somewhat out of date, and we don't know if it how close it is to the reality. So you can develop a CLL registry prospectively as a standalone research project, but it is quite it is difficult. It has to go through several sort of hurdles. One is the design, get all the approvals, including the ethical approval, whether the patient needs to consent or not, whether the data is secure enough or not, etc. And then you have to secure the funding. And the problem with the registries, as you would prospectively, is that the funding is quite difficult, because you don't, these projects are ongoing. If you want to record the outcomes of the CLL population in the UK, you will start with a certain number of people that are currently have CLL, but as you probably are already thinking, the CLL population will keep growing because people keeps being diagnosed, and thankfully, people is dying less commonly of CLL now. So, the amount of people you will be following becomes sort of a snowball. So that funding is not just that the funding that would be needed for this is not just a standalone funding for a few years. It's something that has to be secured for the future. So it's very difficult to set this up, and it also needs a lot of oversight, because the data needs to be continuously monitored, making sure that the data is appropriate and the data is being collected appropriately. So it's quite difficult. So it's helpful for smaller communities such as the Danish, the Dutch, which have allegedly less less people, and they're smaller. But for something like UK would be quite difficult. So then there's the other option, which is the big data, as we call it, which is the data that's stored in the NHS England databases. And we said, and that's the principle of the uncovering. We said, well, let's have a look at what we've got and what we can do with it. And this is the databases that we have. And I'll try to go through them, sort of read quite briefly without too much, without boring you with too much detail. But the cancer registry, so it's basically every time a patient is discussed at NEMDT, which is mandatory for all new cancer diagnoses, there's data that is sent from the hospital into this cancer registry with the code of the diagnosis to then and the NHS England has this information. So you can see that potentially we've got information for all the patients that have been diagnosed with CLL across the UK for several years now. The third one that you can see there is this, we call it the SACT, so systemic anti-cancer therapy. So every time a patient is started on a new anti-cancer therapy, whatever that is, there needs to be certain authorizations from NHS England in terms of funding if the drug is funded centrally, which is the case for most of the drugs we use for CLL, because they're classed as high-cost drugs, and the economic management of those are different. So therefore, we have to register the patient in a web portal and get authorization from NHS England to actually start the treatment. So then that means every time a patient is starting treatment within the UK or within England, let's just say, there will be a registration in these databases for these patients with this characteristic, starting treatment on this given date, etc. And similar things happen with radiotherapy. Similar happens with hospital admissions. There is a coding and a reporting of every hospital admissions that happens in the NHS to a central database. A&E attendances as well, because this is the data the central NHS and the government use to sort of model the requirements of the NHS and the and the patterns of diseases and etc. throughout. So they use this data regularly, and they have it. It's just not usually available to clinicians because of governance, information governance, basically. There's also diagnostic imaging data sets, cancer waiting times, which is basically the monitoring of the time from patients for patients that are referred from primary care into the specialist services for treatment of cancer. There's mapping of the times these patients take to be seen for the first time in clinic, and the times they are given the diagnosis, and the time they take to have the first definitive treatment for the cancer. So then that's another source of information that we can get to be able to map what's happening with cancers globally in England. So there's a long process, because as you can see, sorry, I'm going to go back one slide, because you can see there's several different databases with different columns, different sort of variables recorded in them, with a single unifying sort of variable to them, which will be each patient's NHS number. So there's a long process that needs to take place, setting an infrastructure to open these databases and what we call a curation, which is basically link them up based on the NHS number of each patient and making sure that the information that we store is not duplicated and is adequately assigned to each of the patients. And this is obviously done with very complicated sort of computational algorithms, because the numbers of patients is so vast that it's impossible to do manually. And obviously, after this is done, there's a number of checks that need to be made in order to make sure that the data is entered correctly. So the purpose of the initial project was paying a company that's expert in doing this to try to amalgamate all these databases into one that we call the single UnCoVer database, that will then be stored in the University of Liverpool and will serve to be accessed in order to interrogate whatever we want out of it, depending on the disease and the research question that we're trying to address. So there was an initial release of this database in 2023, and as you can see, there was about 180,000 cancer patients treated within this database. So you can see you can imagine the complexity of the mathematical algorithms and computational algorithms that are needed to curate this database. And there is a second release that has updated the information up until 2022. This initial release contained data only up until 2018 for some of the databases, until 2021 for some others. So we have been able to get a second release with a more up-to-date data, which is going to be a big difference. So this is just another numbers of this database. So you can see we have 53,000 patients who have received systemic chemotherapy within these 157,000. Nearly 50,000 who've had diagnostic imaging results reported. We've got 26,000 attendances to A&E and 143,000 hospitalizations for these patients. That will give us information about what's going on with them. This is the number of patients that we've got, and you can see the CLL just in this graph is the third one from right to left. So it's kind of the third in prevalence in numbers of patients in this database, just behind multiple myeloma and lymphoma in general, DLBCL, which fits with sort of the incidence that we expect of all these hematology conditions. So we have on this first release of the database 17 patients who've been diagnosed with CLL, and from the 53,000 patients that have received chemotherapy, there are about 3,400 who have received treatment for CLL. So we can immediately have an idea that only about 20% of the patients who have been entered in this database, having had a diagnosis of CLL, have received treatment. And that gives us a very good initial idea of what is the watch and wait mean, and what are the numbers for these patients. There's a new data set, as I said, up to date with to more recent dates, and the numbers have gone up significantly up. So we've got now registry for nearly 270,000 patients. So we've nearly doubled the number of patients we had initially. We hope that we'll get similar increases in the number of CLLs and CLL treated patients. So this is a brief overview of what we've got. This is still on its infancy, because we're still sort of in the process of obtaining the data and the data and a solid database that we could use. We had an initial release that I showed you, the data I showed you initially, but unfortunately there were some errors in the database. There were some patients that were not linked appropriately, So we have to go back. They have to go back and revise the algorithms for unifying the databases because there were some flaws in it. So, and it takes a bit of time, but we're hopeful that we'll get a final version very soon. So the other arm of the UnCoVer project is trying to involve patients as much as possible, and try to have advocates of patients within each of these work packages that we've mentioned. So these are the 8 work packages and an overarching steering group of the UnCoVer. And all of them have had already, most of them, I should say, have had already patients involved in them that are providing us advice and sense checking that the research questions we're asking are sensible and relevant to the patient community. Some others are sort of less well developed, and the patient representatives have not yet been appointed because the work still somewhat behind in some of them. But I'm very happy to say that the CLL is probably the one that has gone the most advanced sort of planning towards what is it that we're going to do with the data once we have it. So the CLL project is steered by Dr. David Alsop and myself. We've got some other collaborators, Dr. Williams, Dr. Walewska, but also and the 2 patient representatives, Lilia Dilly and W. Yates. There, and as you can see, this is just a showcase of the other groups and who it is that is involved in terms of clinicians and patient representatives, etc. So what are we doing for CLL? And that's probably the question everyone is really asking themselves. So what are we doing? So we've got 3 initial protocols or questions. And the first one was very obvious, and we're starting to look at very clinical questions, and our patients in the group just said, well, just hang on a minute, because we actually don't have a really good sense of what are the demographics and what is the when is people being diagnosed, what is the age the people is being diagnosed, how long are they on watch and wait for. And it's actually the question that most patients would ask themselves once they're diagnosed. So why don't we actually look at that in this data that will clearly give us a good picture of what's going on within the UK. So that's our first goal, really. And I'm very happy to have been steered by the patients in order to get this as the first good, potentially good outcome of our project. And we've got 2 additional ones. One is treatment sequencing. So as you know, that we've got 2 different groups of medications or treatments for CLL. One is the BTK inhibitors and the other is the BCL2 inhibitors, both of which are used in sequence and now sometimes in combination. And the biggest question that exists on our MDTs really is what to do. Which one should we start with? Which one should and what is the best way to sequence these therapies? Because we don't know yet, and unfortunately, the clinical trials that they do trying to investigate these agents are focus on a single line of therapy. They never focus on what happens after that, following 2 or 3 lines of therapy ahead. So we want to take the opportunity of these, several thousands of patients who've had CLL therapy and try to interrogate what happens with these. What happens with the patients who start on BTK inhibitors and then move to venetoclax? What happens with those who have the opposite? And what happens to people who had chemotherapy before and now had the 2 agents? And if there's any order of these agents that is better than the other? And it's a very relevant and important question for CLL community, I think. We think, and I think that our patients in the group have concurred with us in that. And the third one is quite relevant for this data because it's a cancer diagnosis database. So we want to see what are the secondary cancers in people with CLL. do they vary depending on the treatment you've had and how many treatments you've had and what are the specifics cancer? Is there any one that stands out or not? And have we managed to modify that? Because obviously secondary cancers are a big issue with systemic chemotherapy. And the bigger question is now that we have not been using chemotherapy for some years now, are we managing to reduce that incidence of secondary malignancies and therefore providing patients with sort of a non-perceived benefit or no immediately perceived benefit with the novel agents? So another important question is that we think we can answer. But the project is not going to be confined to these three. Obviously, there hopefully will be many more questions that we want to answer, and we can answer with this database. But these three first are the ones that we thought that will give us the most priority in the first instance. But also, it will help us to sort of test the database and see how much we can get out of it to be able to plan ahead what comes after number 3. There are other UnCoVer projects that are that might be relevant for CLL. And I want to focus on the UnCoVer inequalities and the UnCoVer infection and the UnCoVer cardio. So the infection is basically looking at, what's the burden of infections in patients with CLL, and that's a really relevant question, I think, for the community. But it does apply to most of the hematological conditions, so that's why it's kind of an overarching project of its own. Inequalities is important because we've got sort of GP practice and postcode of all the patients that have been included in this database. So it will help us to identify what areas are, if there's any linkage of the privation index and whether or not that is having an impact in your care and your outcomes with cancer, particularly CLL, but also others. So it might help us to put this in perspective to the NHS England and the regulators, and maybe have some impact on their policies. And finally, cardio, UnCoVer cardio. So cardio oncology is kind of an emergent field in oncology, and there's growing interest of cardiologists that are wanting to be familiar with all the problems that there are with cancer therapies. It is very relevant for CLL because we have a lot of cardiovascular comorbidities, particularly with BTK inhibitors, and therefore it is important that we have some cardiologists overseeing this project in conjunction with our clinicians and hematologists to see if we can get some meaningful data about this as well. So this is just a summary of that. And for the CLL, so they're already very advanced questions. So what is the correlation between BTK and the cardiovascular adverse events? Is there a difference between first and second generation BTKs, BTK inhibitors, and what are the baseline characteristics that would make patients more at risk of this, and can we actually help clinicians to better decide which treatments to give based on what we find? So to summarize, so what is the current status in the future? So first of all, before I go into this, I would like to then obviously give a big acknowledgement to Professor Pettit, Professor Kalkonda, and Catherine Tudor-Smith, which are sort of which we conceived the project and have been sort of putting the wheels in motion for this to go to become a reality. And they've set up a quite impressive team, and they've managed to sort of engage people of different with different interests in different hematological conditions, and maintain that interest throughout a few years now. So they're doing a tremendous job, and I could not finish the talk without acknowledging that. So again, we're hoping to have the released dataset in June or July this year. And with that, we'll get on to work quickly. And for the CLL specifically, I think we should expect to have some sort of publication of data during the next year or two, I think. hopefully during the next year. It depends on how much we have to work on that database, but it's a good aspiration, I think, and I think we will be able to manage to do this next year. And then during this year, the other thing that we want to do is then, once we have an idea of the data set we've got in our hands and how deep and how good it is, then we also want to take the opportunity to have a wider consultation with the patient community, and perhaps the CLL support might be a good tool or a good forum to do this, because we want to. One of the concerns of our patient representatives in the CLL is that they are just individuals expressing sometimes their own individual opinions, and they're really concerned that those opinions might not reflect the opinions of the CLL community, because the CLL people with CLL is very varied, and it's important that we try to capture what, kind of a bigger consensus. So one of our ideas is to organize sort of a larger meeting, and in that meeting, just try to put down the data we've got and how we've got it, and what we can do with it, and to try to get some feedback from patients to guide us to answer those questions that might be more relevant to people. And that is going in line with something that's called the Core CLL Outcomes, which is a larger European project that's called the Harmony Project. It has gathered data for also many patients, including the CLL. And in parallel, they've done very well-designed patient dynamics throughout Europe in order to capture what, but not only patients, their patient dynamics the dynamics that involved patients, that involved clinicians, regulatory, so people from the regulatory agencies, pharmaceutical companies, and they got to a consensus of what should be the outcomes that should be included in CLL research going forward. And we can definitely try to see what of those outcomes are relevant to the UnCoVer database, and how much of those can we focus on with our database, and also ask our local patients of those, what, if there's any difference or discrepancy in what do they think they might be more relevant for locally, compared to the sort of global European, if you will, community, which is what this outcomes reflect. So that's hopefully going to happen during this year, and we hope to be in conjunction with Dr. Alsop and other collaborators, just trying to work out the best way to do this in the future. So hold the space for that. And I'll leave it there. Thank you for your attention, and I'm happy to take any questions.